Hello and welcome to the topic Bradyarrhythmias and Heart Blocks in the Cardiology module. By the end of this session, you should be able to define bradyarrhythmias, classify bradyarrhythmias, outline clinical features of bradyarrhythmias, interpret the ECGs of bradyarrhythmias, identify peri-arrest bradyarrhythmia rhythms, and finally discuss the principles of management. Let's get started. Bradyarrhythmia, which is derived from the Greek term brady means slow and arrhythmia meaning abnormal rhythm, describes an abnormal heart rhythm combined with a rate of less than 60 beats per minute. Bradyarrhythmias may be classified into disorders with impulse formation and disorders with impulse conduction. Impulse formation disorders are disorders with the initiation of impulse from the SA node. Examples of these disorders are sinus bradycardia, sinus arrest or pause, and tachybrady syndrome. Let's look at each and every examples individually. Sinus bradycardia. This can be defined as a sinus rhythm with a resting heart rate of 60 beats per minute or less. ECG strip typically shows a sinus rhythm where a normal P wave is followed by a QRS complex. This rhythm can be physiological or pathological, which is observed in sick sinus syndrome or in the use of certain medications like beta blockers and calcium channel blockers. Sinus arrest or sinus pause is defined as the transient absence of sinus P waves on the ECG that may last from 2 seconds to several minutes. Here, the sinoatrial node of the heart transiently ceases to generate the electrical impulses. Next would be tachybrady syndrome. So tachybrady syndrome is identified by bradycardia alternating with paroxysmal supraventricular arrhythmias, most frequently atrial fibrillation. This results from abnormal automaticity and conduction within the atrial tissue. Now let's look at impulse conduction disorders. These are disorders with impulse propagation along the conduction pathway in the heart, mainly from the SA to the AV node or from the AV node to the His Purkinje fibers. Examples of these disorders are atrioventricular blocks and bi- or trifascicular blocks. Here on, we will be looking at the different types of AV blocks and bundle branch blocks. Let's dive into it. Alright, so the normal electrical activity of the heart starts in the sinoatrial or SA node located near the opening of the superior vena cava into the right atrium. Electrical activity is then conducted through the atrium to the atrioventricular or AV node, after which it goes through the bundle of His, then the right and left branches of the bundle, and finally through the Purkinje fibers which deliver the current to the right and left ventricles. Now, normally there's a delay in conduction at the AV node and the bundle of His, which gives some time for the ventricular filling before the ventricle contracts. An atrioventricular block occurs when conduction is delayed for too long at the AV node or the bundle of His. Also, electrical activity may be blocked at the level of the bundle branches, which are called bundle branch blocks. Alright, on the ECG, the normal delay in AV node is represented by the PR interval, which is normally less than 5 small boxes or 200 milliseconds. Let's look at the first type of AV block, which is the first degree AV block. Describes a PR interval greater than 200 milliseconds. The SA node produces a regular electrical impulse that travels through the atria and into the AV node where it stalls. The QRS complex is typically narrow, implying the block is in the AV node. A first degree AV block is usually asymptomatic and is diagnosed on ECG. It can progress into a second or third degree AV block and requires regular monitoring. Common causes of AV nodal disease include enhanced vagal tone, characteristically seen amongst athletes, myocarditis, acute inferior myocardial infarction, electrolyte disturbances, and medications. Common drugs associated with this are calcium channel blockers, beta blockers, and digoxin. Second degree AV block is diagnosed when one or more, but not all, of the atrial impulses fail to conduct to the ventricles due to impaired conduction. There are two classes of second-degree AV block, which is Mobitz 1, also called Wenckebach, and Mobitz type 2. Mobitz type 1 second-degree AV block is an irregular rhythm because the PR interval progressively lengthens until a QRS complex is dropped. The defect is at the AV node and is usually the result of excess parasympathetic tone on the AV node. Mobitz type 1 is often asymptomatic. On the other hand, Mobitz 2 can be dangerous and may result in severe bradycardia and decreased cardiac output. The medical significance of this type of AV block is that it may progress rapidly to complete heart block, in which no escape rhythm may emerge. Therefore, the definitive treatment for this form of AV block is an implanted pacemaker. Next would be the third-degree AV block or complete heart block. In this type of heart block, none of the electrical impulses are conducted through the AV node, and that's why it's also called complete heart block. Remember that all the cardiomyocytes are capable of starting their own electrical activity, a property called automaticity. So in third-degree AV block, the ventricles recognize that they are not getting any impulses and respond by generating their own electrical rhythm called a ventricular escape rhythm just to hang on to their dear life. Because the atria and ventricles each have their own pacemakers, they now contract independently of one another, which is called AV dissociation. This desynchronization of the heart chambers can reduce cardiac output dramatically, leading to syncope or even sudden cardiac death. On the ECG, the P waves and QRS complexes have nothing to do with each other, each appearing at their own rates. The atrial rate is 60 to 100 beats per minute, whereas the ventricular rate usually ranges between 30 to 45 beats per minute. Because of how dangerous third-degree blocks are, anyone diagnosed with it requires a pacemaker. Third-degree heart blocks is commonly caused by coronary ischemia, followed by progressive degeneration of the electrical conduction system of the heart. It can also be caused by hyperkalemia, Lyme disease, and congenital causes where association with maternal lupus has been shown. Congenital heart block is a complication of neonatal lupus. Here, the maternal autoantibodies called anti-Rho and anti-La antibodies cross the placenta and attack the conduction system. Now, let's take a look at bundle branch blocks. In the right bundle branch block or RBBB, the high yield effect is to remember that QRS complexes in the right-sided chest leads, which are V1, V2, and V3, show an RSR configuration. This means a pronounced R wave followed by a deep S wave and then another R wave. This gives the QRS complex the appearance of rabbit ears or the capital letter M. To remember this, think RBBB equals rabbit ears in the right-sided chest leads. Causes of RBBB include right ventricular hypertrophy, right heart failure, and pulmonary embolisms. These causes are due to right heart not functioning normally, so there is delayed conduction through the heart tissue. Also, for unknown reasons, RBBB can be present in normal hearts, possibly due to deposition of fibrous tissue that interrupts the conduction pathway. Now, let's look at left bundle branch block or LBBB. Similar to RBBB, the QRS complexes will be wide because of the delay in ventricular depolarization. In leads 1, AVL, V5, and V6, tall R waves are present, and in lead V1, broad, deep S waves are characteristic. Additionally, there may be ST segment depression and T wave inversion. When we talk about causes, unlike RBBB, LBBB never occur in normal hearts, so there's always something wrong. Examples include hypertension, ischemia, dilated cardiomyopathy, and aortic stenosis. Similar to the causes of RBBB, these disorders affect the left ventricle, causing a delay in conduction through the cardiac tissue. Importantly, a new LBBB in an individual presenting with chest pain may be a sign of myocardial infarction. Next would be bifascicular block. A bifascicular block is a conduction abnormality in the heart where two of the three main fascicles of the His-Purkinje systems are blocked. Most commonly, it refers to a combination of right bundle branch block and either left anterior fascicular block or left posterior fascicular block, with the former being more common. Next would be a trifascicular block. If associated with syncope, trifascicular block represents an indication for pacing on both prognostic and symptomatic grounds. When determining treatment, it is important to differentiate reversible conditions from irreversible conditions. Reversible conditions do not require a permanent pacemaker. They include increased vagal tone, infections such as myocarditis or endocarditis, electrolyte imbalance such as hyperkalemia or hypermagnesemia, medications such as beta blockers, calcium channel blockers, and mild ischemic events. Permanent causes of AV block require a permanent pacemaker. These include degenerative changes, fibrotic changes caused by sarcoidosis and hemochromatosis, and surgery, such as ablations or valve repair. A permanent pacemaker is an implanted device that provides electrical stimuli, thereby causing cardiac contraction when intrinsic myocardial electrical activity is inappropriately slow or absent. Now let's look at the indications for a permanent pacemaker placement. Firstly, if there's persistent symptomatic bradycardia, such as in sick sinus syndrome or complete heart block, Mobitz type 2 AV block, and persistent AV block after myocardial infarction. The other indications could also include second-degree AV block with any of the following, which include symptomatic bradycardia, documented periods of systole of 3 seconds or more, any escape rate less than 40 beats per minute in awake asymptomatic patients, type 2 second-degree AV block, and a ventricular rate of 45 beats per minute when awake and asymptomatic, as well as persistent AV block after myocardial infarction. Pacemakers are classified by the nature of their pacing mode using a code up to 5 letters. This slide shows the NBG pacemaker code, which was developed by the North American Society of Pacing and Electrophysiology and the British Pacing and Electrophysiology Group. Let's look at single chamber pacemakers. Here we have the VVI, which means there is one lead in the ventricle, pacing and sensing the ventricle, indicated by VV. VVI pacemaker will pace and sense the right ventricle. VVI pacemaker is useful when we are not too concerned about atrial activity, especially in patients with atrial fibrillation. In the presence of organized atrial activity, a VVI pacemaker may pace the ventricles out of sync with the atria, resulting in pacemaker syndrome. Since organized electrical activity is present, a DDI pacemaker would be preferred, as this senses and paces both atria and ventricle to preserve synchrony. Next, we can talk about the dual chamber pacemakers. Having pacing electrodes in both the right atrium and the right ventricle, they allow maintenance of the physiological relationship between the atria and the ventricular contraction, and also allow the paced heart to follow the increase in sinus rate that occurs during exercise. And the final type we have is biventricular pacemakers. Pacemaker leads are placed in the right atrium, right ventricle, and the left ventricle. It's useful in the management of patients with heart failure who have evidence of abnormal intraventricular conduction, most often evident as left bundle branch block on ECG, which causes deranged ventricular contraction or dyssynchrony. Now let's take a look at the peri-arrest bradycardic rhythms. The 2015 Resuscitation Council UK guidelines emphasize that management of bradycardia depends on, firstly, identifying the presence of signs indicating hemodynamic compromise, such as adverse signs. Next would be to identify the potential risk of asystole. The adverse signs are following factors indicate hemodynamic compromise and hence need for treatment, such as in a state of shock, where there is impaired consciousness, syncope, myocardial ischemia, and heart failure. So atropine is the first-line treatment in this situation. It is given up to maximum 3 milligrams and the beginning dose would be 0.5 milligrams intravenously. If there is an unsatisfactory response, the following interventions may be used: transcutaneous pacing, or isoprenaline or adrenaline infusion titrated to response. Specialist help should be sought for consideration of transvenous pacing if there is no response to the above measures. You want to consider potential risk of systole. So the following are risk factors for asystole. Even if there is a satisfactory response to atropine, specialist help is indicated to consider the need for transvenous pacing, especially in complete heart block with broad complex QRS, recent asystole, morbid type 2 AV block, and if there's ventricular pause for more than 3 seconds. So let's summarize. AV node block is divided into 3 major subtypes. First degree AV block, which is simply a prolonged PR interval. Second degree AV block, which has 2 subtypes, morbids 1 and morbids 2. Morbids type 1 is characterized by a progressively prolonging PR interval followed by a drop beat, and morbids 2 has a normal PR interval followed by a sudden drop beat. In third degree AV block, there is no relationship between the P waves and the QRS complexes, a phenomenon known as AV dissociation. Bundle branch blocks all have widened QRS complex. In RBBB, an RSR complex or rabbit ears appear in the right-sided precordial leads. In LBBB, there are tall R waves in leads 1, AVL, V5 and V6, as well as deep S waves in lead V1. We have come to the end of this topic. Thank you.